Good afternoon. Uh, this is slightly different case than what we have discussed so far. This is a case of gunshot injury in the abdomen, where the patient presented after 2 surgeries with a continuous murmur in abdomen and recurrent melena. So this was a 25-year-old male, had gunshot injury about a month back, underwent 2 abdominal surgery. He presented with recurrent melena and continuous abdominal murmur. And it was referred to us by our gastroenterologist surgeon. I will just show you the angiographic finding. There was aneurysm of one branch of mesenteric artery, and there was a mesenteric arteriovenous fistula where the venous system was filling abruptly. Now this is a non-selective angiogram in the aorta. One can see there is an aneurysm from one of the branch of mesenteric artery, and there is a very rapid filling of a vein, and then the dye soon appears in inferior vena cava. So the diagnosis was largely clear that we are dealing with a AV fistula as well as mesenteric artery aneurysm. Now to further define what is the feeding vessel to the aneurysm as well as to the AV fistula, we went further selective. Here is, we are just at the ostium of the artery which is having aneurysm. There are other arteries surrounding it. This is again selective injection to the branch other than which was supplying the aneurysm, but one can see there is a collateral or just a branch which is supplying the artery which had aneurysm also. So this branch was also important. So hardware, this patient was a very poor patient. We had very limited in terms of finances. So most of the coils which we used were handmade coil made from 0.035 guide wire on the table itself. Now here we have taken a JR guiding catheter, and then there is a multi-purpose catheter through it, and we tried to weld super selectively. This multi-purpose is distal to the aneurysm in the same branch which is feeding the aneurysm, and here there is AV fistula. We can see the filling of AV fistula. The plan was to embolize the whole tract, since there are other branches which can feed this subsequently. And this is actually the site where the AV fistula actually is being fed. So since this branch was very small and it was not possible to use handmade coils, we have taken a micro catheter, went selectively to this branch, and initially deployed a few 0.018 guide wire coils. This is the first coil which is going. And subsequently we filled 2 or 3 more coils, and then we started with our handmade coils. These are rest coils, rest are all handmade coils. The coil is dancing in the aneurysm. Few more coils going inside. And this was the last coil which completely obliterated the whole tract. And this is the angiogram in the feeding vessel, where we can see there is total obliteration of the tract. We went down in the branch up. There is no residual filling in the aneurysm or AV fistula. We went down in the lower branch, and again there is no feeder to the AV fistula. This aneurysm will clot, we know. And this is the final angiogram. There is no more AV fistula now, and the aneurysm is totally sealed. This case was done about 2 years ago. The patient remained asymptomatic since then. Thanks.